At a microscopic level, lipedema operates differently than standard obesity. Normal lipid droplets expand evenly to store energy, but in lipedema, adipose tissue transforms into fibrotic, swollen lobules. These enlarged fat cells become trapped in a rigid matrix, physically compressing local nerve endings and constricting delicate lymphatic vessels. This cellular trapping creates a specific visual signature. The classic presentation is a bilateral, symmetrical accumulation of fat, most commonly across the hips, thighs, and calves, stopping abruptly at the ankles to form a distinct cuff. Onset almost always aligns with major hormonal transitions, puberty, pregnancy, or menopause. As the fibrosis deepens, the physical structure of the limb changes. Stage 1 presents with a smooth skin surface over enlarged fat. By stage 2, the tissue forms palpable, irregular nodular deposits, resembling walnuts beneath the skin. In stage 3, these deposits coalesce into large, heavy lobular masses that cause significant anatomical deformity. Clinical statistics from a large Swiss referral center detail the physical toll of the disease. Nearly half of patients present at stage 2. Alongside the primary diagnosis, over 86% suffer from chronic venous disease, 51% face concurrent obesity, and a striking 88% report significant, ongoing tissue pain. These markers confirm that lipedema is a structural disease of the connective and adipose tissue. It requires specialized clinical recognition, independent of standard metabolic health metrics. When patients attempt to manage this condition through calorie restriction, they encounter a harsh biological reality. No dietary intervention has been proven to reduce the pathological fibrotic fat unique to lipedema. This line graph tracks an 8-week randomized controlled trial comparing a low-carbohydrate diet to a standard control. The low-carb group achieved a 2.8 kilogram greater weight loss. However, the critical finding is the second trend line. Patients reported a 1.1 point drop in pain scores that occurred independently of their weight loss. Relief is driven by cellular chemistry. On a low-carbohydrate or ketogenic protocol, the liver produces ketone bodies like beta-hydroxybutyrate. When this molecule enters the cell, it inhibits the NLARP3 inflammasome and suppresses NF-kappa B signaling, turning off the localized inflammatory response. Other anti-inflammatory approaches show different biochemical signatures. High adherence to a Mediterranean diet drives down systemic inflammatory biomarkers, specifically lowering circulating levels of TNF-alpha and IL-6. While the measurable inflammation drops, these patients do not always experience immediate pain relief. Precision nutrition in lipedema serves to cool the aggressive biochemical environment and provide symptom management. It does not cure the localized adiposity. Clinical interest in GLP-1 receptor agonists for lipedema is high, but direct evidence is scarce. A comprehensive 2026 review found only 13 publications touching on the subject, yielding exactly one uncontrolled case series tracking just 5 patients. Despite the lack of trials, the theoretical mechanism is compelling. Lipedema tissue is characterized by chronic inflammation. GLP-1 molecules interact with immune cells in the fat depot, triggering macrophage colorization, shifting aggressive pro-inflammatory M1 macrophages into tissue-repairing anti-inflammatory M2 phenotypes. This comparative bar chart breaks down the fat mass reductions achieved by different GLP-1 agents in general populations. Tirzepatide leads with an average reduction of 9.6 kilograms of fat, followed by semaglutide at 3.8 kilograms and liraglutide at 2.4 kilograms. Because bariatric surgery produces significant weight loss without reducing lipedema pain or localized fat, clinicians question whether GLP-1s will follow the same pattern. If these drugs primarily metabolize normal truncal fat, while the fibrotic tissue remains resistant, the physical disproportion could become more pronounced. GLP-1s provide a tool for managing the metabolic health of the half of lipedema patients with concurrent obesity. They address the broader metabolic burden without targeting the specific localized pathology. When conservative measures fail to halt the progression of symptoms, clinical guidelines point to surgical intervention. Regardless of the disease stage, the absolute prerequisite for surgery is a dedicated 6-month trial of complex decongestive therapy, combining manual lymphatic drainage, flat knit compression, and aquatic exercise. If the tissue remains painful and mobility continues to decline after 6 months, patients become candidates for the surgical gold standard, lymphatic-sparing wet or tumescent liposuction. Older, aggressive dry liposuction techniques damage the delicate lymphatic vessels and are now obsolete. Modern techniques yield specific, measurable outcomes. Ultrasound-assisted methods demonstrate average circumference reductions of 6.4 centimeters per limb. Selective combined approaches, utilizing power-assisted and Vaser technologies, report an 89% reduction in tissue pain and a 91% improvement in mobility. While these observational outcomes are strong, the standard of care is being tested by the ongoing LIP-LEG trial, a randomized controlled study pitting this surgical protocol against continued conservative therapy. Effective lipedema management requires a rigid sequential matrix. It begins with identifying the clinical signature, deploying targeted nutrition and GLP-1s to control systemic inflammation, establishing a 6-month decongestive baseline, and escalating to lymphatic-sparing surgery to extract the fibrotic burden.